Good morning. It's July the 12th, 2022. I get a lot of questions about why can I have all of these symptoms with normal urinalysis, normal or negative culture, and negative DNA PCR tests. Those are great questions that we really don't have all the answers to. But amazingly, most of the patients with these severe lower urinary tract symptoms, their dipstick most of the time is negative. And that's why they've been pushed down this rabbit hole, because doctors see a negative urine. Most people just use a dipstick now and see this negative urine, and obviously they're ingrained to think that if the urinalysis is normal, then there really can't be anything going on in the urinary tract. Just it's not the case. Also, how can you have a florid infection and a negative urine culture? The main reason you have a negative urine culture is not necessarily because the urine culture is negative. The urine culture was interpreted to be negative. It doesn't meet particular standards which have been passed down for 50, 60, 70 years now. Most of the time, those urines actually do have bacteria grow on them, but they don't meet the historical standards for infection, which is, again, another reason why the patients get pushed down this rabbit hole of IC, overactive bladder, etc. So another concept is, how can you have a negative DNA, negative urine DNA? Well, the reason that happens is this is a bladder wall, bladder lining, an epithelial infection. It's not necessarily an infection of the urine. So if the bacteria are not in the urine, the urine DNA tests are going to be negative. You can have patients that have a normal or negative urine DNA, look in their bladder, and clearly see, cystitis cystica, which is an indicator of chronic infection. And that gets to another topic, which is cystoscopy. And who needs cystoscopy? Well, that's another question that we're going to have to revisit. The problem with cystoscopy is that urologists have spent all of their time and energy during cystoscopy trying to rule out bladder cancer or some other anatomical pathological problem, and basically they've ignored the reason why. It's come from using cystoscopy to determine why people are having problems, to determining during cystoscopy that somebody doesn't have bladder cancer. Oh, cystoscopy's negative, you don't have bladder cancer, no problem. Well, there is more to cystoscopy than ruling out bladder cancer. I mean, I've been that doctor. I get it. That's something dangerous that you don't want to miss. But it's gotten to where you can see the people or urologist thought process is that let's do a cystoscopy and rule out bladder cancer, but they don't drill down into what's causing the patient's symptoms, which is, if you really look, you can see areas of cystitis cystica in these patients. you can see, hyperplastic polyps in the urethra that are a secondary response to infection. So the question about when to use cystoscopy, I mean, we have lots of, clear-cut indications for when to use cystoscopy. But instead of, every cystoscopy being done to rule out bladder cancer, we should spend more time using cystoscopy to determine why patients are having the problem that they're having. Recurrent UTIs is another common indication for cystoscopy. Recurrent UTIs is one of the catch-all terms for this problem of chronic bacterial cystitis. So you do a cystoscopy for recurrent UTIs, and yeah, there's no bladder stones, there's no bladder tumors, but you don't really look at the trigone really carefully to determine that, oh, well, that's cystitis cystica right there. You have a chronic infection. That's why you have microscopic hematuria. That's why you have frequency and urgency and maybe pain. So if we spent more time trying to determine why people have the symptoms they have when you're doing cystoscopy, I think we can do a better job. But yeah, cystoscopy's overutilized. I mean, I see people all the time that come from wherever that they've had 3 or 4 cystoscopies in the past 3 years. That's just a waste of resources. So we need to do a better job of utilizing cystoscopy, and then when we do cystoscopy, try to find some answers. Try to find out why people are having problems instead of ruling out bladder cancer or bladder stones, which, and most of these female patients, and a lot of them are young and have really no risk factors for either one. Bladder stones you hardly ever see in females, and bladder cancer is exceedingly rare in these, not impossible, but exceedingly rare in these 20, 30-year-old patients that we're seeing now with chronic bacterial cystitis. That's it for today. I'll check back in a few days. We'll come up with another topic. I have a whole list that you guys provided of things that we can talk about in the future. Thanks.